I have given the task of discussing about the role of immunotherapy in combination with either TKIs or with ARP inhibitors in metastatic CRPC. So the first study is the CONTACT-2, which is the Cabozantinib plus Atezolizumab versus second novel hormonal therapy for the patients who have a metastatic CRPC. Let's say we see that after progression on the first line novel hormonal therapy, prognosis becomes very poor and worse for patients with visceral mets especially. And the other non-targeted therapy options after first, the novel hormonal therapy includes either chemotherapy in the second line or the second non-hormonal therapies. Phase 3 COMET study was initially which showed that Cabozantinib, which is a TKI, has a survival benefit in the patients who have been initially treated with CRPCs with visceral mets. So Cabozantinib basically has shown that it has an enhanced response to immune checkpoint inhibitors while generating an immunopermissive environment. So it may be combined with an immunotherapy. So the COSMIC-21 study, which shows that Cabo plus Atezo in post-hormonal therapy patients have a clinically active disease with a safety efficacy profile. And so thereafter came the CONTACT-2 study, which is Cabo plus Atezo in combination with the second novel hormonal therapy in the patients with visceral mets. So if we see this study design, so they have been the metastatic CRPC with PSA progression, or there's a soft tissue disease progression after prior novel hormonal, and they should have a measurable extrapelvic disease. That is the most important thing. So either Cabo plus Atezo or a second drug, that is Enzalutamide or Abiraterone, has been studied. And with the primary PFS in this subset of the patient, and the second key secondary endpoint is the overall response rate. So as we see, the median age, all things are well balanced. It's something around 71 years in both the subset, with the most patients with ECOG 1 and 0 and 1 only in this subset. And the median PSA, as we see in this case, is very low, I'll say 34 and 25. And the Gleason score is very much high, that is more than 8 in around 60% of the patients have got bone mets, and visceral mets are seen in something around 40% of these subset of the patient, and with liver mets involving 23%. Important thing is about docetaxel. So with the patient who have got a castrate-sensitive disease, and that time they have something around 1/4 of the patient has received prior docetaxel in this subset. And the initial therapy, as we say, the whether Ibera or Enza, which has been used, is used for a year in this subset of the patient. The PFS, if we see with Cabo plus Atezo, is something around 6.3 months in the intention to treat, as compared to the second novel hormonal therapy, which is 4.2 months. And in those with the intention to treat population, so it's more or less same in all the subset. So if we do a subgroup analysis, if we see that if all the patients, if the overall subset we see, the maximum benefit are seen in the patients who are elderly, that is 65 to less than 75 or more than 75, with the hazard rate going at 2.61 in this subset of the patient. And those with liver mets, they also showed a better survival in combination with Cabo-Nivo. And those who also received prior docetaxel has shown a good response as compared to the second novel hormonal therapies. And if we see with this, those patients who are the metastatic CRPC, so if the hazard rate wise, we see those having a more Gleason, that is more than 8, they have a better hazard. So all those high risk group patients, whether they are elderly patients or those who have received prior having liver mets or with the prior docetaxel, all these have shown an important benefit with Cabo plus Nivo as compared to those with the second novel hormonal therapies. So the interim OS analysis also has been shown with that it is something around 16.7 months in the intention to treat population as compared with the 14.6 months with the hormonal therapies. And if we see those with liver mets, it is 16 months as compared to 9.8 months. And those with prior docetaxel, there's something doubling, that is going to 21 months as compared to 11 months in those with the second novel hormonal therapies. And even with the bone mets. So all high-risk group patients are showing a better benefit with Cabo plus Atezo in this subset of the patient. And we may also see a complete response, and one patient has got a complete response, and the number of partial response is something around 13% of the patients. So the overall response rate is also 14% as compared to the second novel hormonal therapy, which is only 4%. So this combination is, I think, so is now coming in picture. So additional key points, so median type 2 next chemotherapy is not reached in both the subset, but to the symptomatic skeletal mets, it is something 16 months as compared to 13 months. Though the time to pain progression are same, that is around 4 months. And the time to deterioration of quality of life is also same, that is 2.2. So the treatment exposure and discontinuation rate, if we see that the median duration of exposure to the drug was something around 5 months, 4.7 months in both the adverse event leading to dose reduction is around 40% in Cabo plus Atezo as compared to the novel hormonal therapy. And due to the holding dose is something 63% of the patient have to hold treatment and 46% have to delay treatment. So these are the side effects due to which they have to see that. The most common adverse event was diarrhea, decreased appetite, fatigue, nausea, asthenia, transaminitis, or ticket base. All these are higher with Cabo plus Atezo as compared to the second novel hormonal therapy. So the investigators concluded that this therapy result, Cabo plus Atezo, has resulted in a significant improvement in PFS as compared to the second-line novel hormonal therapy for those with metastatic CRPC, and benefit was observed in pre-specified subgroups, including liver mets, prior docetaxel, and bone disease. An interim OS analysis also found an improved OS with Cabo plus Atezo, and they have safety considerations were as consistent as with the earlier, which has been seen. So all these data supports their role in the metastatic CRPC. So this might be the new regime which may be acting after the initial progression on the first-line therapies. But now coming to the second trial, that is again an immunotherapy in combination with an ARP inhibitor, that is enzalutamide, pembro plus enzalutamide for patients with metastatic CRPC. It's a Keynote 641 study. They have also taken a CRPC with prior abiraterone was only permitted without any prior docetaxel in this subset, or any enzalutamide, apalutamide, or darolutamide. And the patient has been stratified in randomized to pembro plus enza as compared to enza in this subset. With the primary endpoint, they have taken overall survival or radiological progression-free survival in this subset. The baseline characteristic we see are well matched. That is something around 71% of the 71 years is the median age, and maximum patients were ECOG 0 or 1. There is no ECOG 2 patients, and the mets are something around 12%, though the bony mets were 85% in this, and there are very less patient with the liver mets, only 3.5% in this subset. And if we see the PDL1 positivity stated, it is something around 30%, 27 to 30% in both the subset. The primary endpoint, which was the OS in this subset, so if we see the events for the OS percentage, it more on it's same. It's basically in the pembro plus enza, it is 24.7 months as compared to the placebo plus enza, which is 27.3. So it is slightly detrimental in the immunotherapy arm as compared to those with the only ARP inhibitors. The radiographic progression-free survival, though it was higher in the pembro plus enza subset, that is 10.4 months as compared to 9 months in the enza, but it doesn't translate it to the overall survival benefit. So if we see the time to initiation of first subsequent therapy in the pembro plus enza arm, it is 13.2 months as compared to 12.6 months in only the enza arm. But the important thing is in this trial, what we see, there is some patients have achieved a response. That is 7.4% of the patient have CR in the pembro plus enza as compared to only 2.7% with enza alone. And this received prior abiraterone, something to 2.2% of the patient have in this setup has received prior abiraterone. And the partial response rate is around 25% in both the subset, and stable disease also 39% in both the subset. So if we see the secondary endpoint safety, that is the most important thing. So there are much more higher adverse events in the pembro plus enza, that is more rashes, and this have patients with more fatigue. Grade 3 adverse event was something around 56% as compared to 41% with only enzalutamide. And the toxicities leading to death is around 6% as compared to 2% in the 2.4% in the other subset. So to conclude that this trial was stopped initially because of the OS futility after the first interim analysis. The addition of pembro to enzalutamide in participants with chemotherapy naive with or without prior abiraterone did not improve either radiographic progression-free survival or OS. There was no notable difference in both this primary endpoints as compared to those who have received prior abiraterone therapy. And it is associated with more treatment-related grade 3 toxicities. But the important thing that few patients have got a complete response. So might be we have more patient selection has to be and more predictive markers needed to combine the immunotherapy in combination with the ARP inhibitors. With this, I'd like to end. Thanks.